Okay, any questions from material prior to this? Continue on with pediatrics. I'm sure you guys have covered a little bit of that recently, so you guys should be well aware. Do you guys remember the pediatrics lecture from pharmacodynamics? Nope. Right, so that's why we're going to review that, so we can make sure we're familiar with Peds differences in pharmacokinetics and whatnot. And then we'll actually get into how to treat some kind of common ailments, and then we'll talk a little bit about cystic fibrosis, just because I think it's kind of an interesting, kind of a unique disease state you deal with a lot in pediatrics, and has some kind of unique drugs that you don't see used much elsewhere. I had a thing that I was going to go somewhere with, and I don't remember what it was now. That's okay. We'll continue on. But anyway, so I have to use this opportunity, especially with it being Valentine's Day, to dote on my little daughter. So when you deal with patients like her, yeah, she's pretty cute. So she does look a lot like me. She is. I don't have to do the paternity test or anything to. She's definitely mine. Yeah. So anywho, she's very cute. But anyway, so why is she so different than you see with a lot of other types of patients? So obviously, you know, pediatrics, they're just little adults, right? Obviously, no, they're not that. They're a pretty heterogeneous population, and so even, you know, between month to month, you know, you can see big changes, especially when they're very young like that. You know, my daughter's 8 months old, so she has just developed, you know, tremendously even in the past, like, you know, 4 weeks. You know, now she's crawling and she can, you know, pick up Cheerios and all kinds of cool stuff that you get to see with that group. But there's lots of physiologic changes that are happening as well. And so some of the problems we run into dealing with pediatrics on a day-to-day basis is, do we have a lot of good, like, trial, you know, randomized controlled trials dealing with drugs in pediatric patients? No, and why can't we do those?
Not a lot of volunteers.
Not a lot of volunteers. Like, yes, please take my child for a scientific experiment. Like, not a lot of, you know, people are up for that. But the other thing is that you run into, they're a protected group, right? So you can't just, you know, give drugs to one group of kids and not the other ones. It's kind of hard to do that ethically. So a lot of the data that we use to treat kids, especially with medications, ends up coming from adult data. So you have to kind of back extrapolate some of that, and hopefully all of it applies, but you may run into some situations where it doesn't. So not only do you run into issues with having lack of data, but you see that kids will process drugs very differently depending on their age. Sometimes they will process it more quickly than an adult might. Sometimes they will do it more slowly depending on what you know, the stage of development they're at. And then you also are going to have kind of age-dependent changes on the disease states as well. So that can all be affecting how we're going to be treating this. So basically you have to kind of go back and kind of look at this from a rational approach. That's why you need to really make sure you're checking your drug dosing for a lot of this stuff, so you can go back and say, okay, well, my kid is 3 months old. How am I going to treat this versus if they were 6 months old? Because the dosing can change pretty significantly, and you can run into some issues with that, right? So just to start out with, just a little bit about the pediatric lingo. You guys kind of know this, but we'll just review it here for just completeness sake. And this is important when we're discussing, especially kids who are in the NICU, right, the neonatal intensive care unit, run into some issues with drug dosing, especially based on what their gestational age is, right? So gestational age is just what? Yeah, time. Yes. How long did that bun get to bake before it made its you know, appearance in the world? Right. So it's how long the child was able to kind of gestate and develop. And so you can see massive changes in development between, say, like a 24-weeker who is just barely able to be viable versus, say, like a 36-weeker. Right. So massive changes there. And so the way that they can process drugs and the maturity of their organs varies pretty greatly. So we'll go over those in more detail. The postnatal age is just that kind of chronological age after they're born, and then postconceptional age is just the two added together. And so sometimes these will come up when you're specifically looking at different drug dosing regimens. You may say, like, okay, based on postconceptional age, they're this, or you may just be looking at gestational age. So very frequently, if you're looking at the pediatric dosing for something, it'll say, like, you know, for gestational age 32 weeks or under, or above 32 weeks gestational age, your dosing will change pretty significantly. You know, especially with things like renal clearance and hepatic clearance of different drugs. So we will call preterm babies those that are less than 37 weeks gestation, full term being 37 to 42, and then you have kind of your post-term babies as well. We will refer to that first month of life when they are neonate / newborn. And then that infant, while technically it kind of runs from 1 month to 12 months of age, you'll probably hear a lot of kids in that first month still being called an infant. So kind of technically kind of expands that whole first year of life or so. So you may hear me kind of say the two terms interchangeably, but if I say newborn or neonate, I'm really just referring to that first month, okay? Then as they get older, they get kind of the toddler stage in that first 1 to 2 years, and they get young child, older, and then adolescence. So kind of at what stage do you think we start to treat them more like adults? Yeah, generally in the adolescent stage, once they start to get up to like an adult-sized patient, you start to treat them as an adult patient for the most part. You may see some differences in specific drugs, but for the most part, they end up getting treated very similarly to adults. Because again, anytime you're dealing with things like weight-based dosing, you never want to go above the adult maxes unless you have a really compelling reason to. And there generally are not very many of those. So if you have a 16-year-old linebacker who weighs 220 pounds, you're not going to give him the same kind of weight-based dosing as you would say his little sister who is say only 40 pounds or something. So sometimes you'll see, especially with older children, you run into some issues, especially with childhood obesity being a big thing. You're seeing a lot of kids who are coming in. I've seen some 7-year-olds who are pushing 100 kilos. They get to be, you'll be surprised some of the kids you have running into. I was probably one of those kids as well. And so you have to look at their weight-based dosing, kind of take that with a grain of salt as well to make sure you're not kind of overdosing them based on the fact they have a lot of extra adipose tissue and the volume of distribution is going to be different for them. You guys remember volume of distribution? What is that?
All the tissue the drug spreads out evenly throughout.
Exactly, yeah. So that's based on the lipophilicity, the hydrophilicity of the drug. So you have a drug that's very lipophilic, and the patient has a lot of extra adipose tissue, you're going to have a larger volume of distribution because there's a lot more space for the drug to disperse out into. Versus hydrophilic drugs, they will not have a kind of commensurate increase in volume of distribution necessarily, and so you can run into some issues where if you have a very hydrophilic drug and you try to dose them based on total body weight, you can run into some issues with that because again, you'll have too much kind of being sequestered in that kind of central circulation. Risk for toxicity develops. Okay, so especially for things like some of our water-soluble antibiotics, like amine glycosides, that can be a big issue with those patients. So I think I posted this article up into the Blackboard site, so that's a good one for review of age-based pharmacokinetic changes. Published, I believe it was in either JAMA or the New England Journal of Medicine. Despite this baby being very creepy looking, it has lots of good information regarding different metabolic changes that are occurring within the developing infant, right? So we're going to look at things like, what's their, the integumentary development like? What is their skin like compared to older patients? How are they having changes in things like gastrointestinal function? Looking at distribution, based on, because, little kids especially, they're just basically big bags of water. So you find the volume of distribution kind of changes pretty greatly for them. And then we'll look at different things. And so basically kind of running through absorption, distribution, metabolism, and excretion. So the ADME of pharmacokinetics, we're going to hit all those points for these patients. So first thing we're going to look at absorption. You guys remember kind of the key factors for absorption, especially for kind of just passive diffusion of medications. A lot of it is related back to the molecular weight. So obviously things that are smaller or bigger have an easier time passing across biological membranes. Smaller, right? Things are smaller are going to have an easier time. Again, smaller particle size kind of goes along with this. Because remember that Henderson-Hasselbalch equation? With maybe some repressed memories there, some PTSD. But yeah, pH and pKa are going to be a big factor here. So looking at things like the changes in the pH of the GI tract, especially early on in the pediatric development, can change the ionization state of the drug. And so things that have a charge on them, are they easier or harder to cross those membranes? Harder, right? So things that have a charge on them are be more difficult to cross those membranes. You have less absorption. Things with no charge are more fat soluble, they can get across easier. And then the dosage forms are going to matter as well. Obviously, what kind of dosage forms do we use a lot in pediatrics? We use PO. What specific types? Can you kind of give like a big tablet to a 2-year-old? Yeah, so you're running across a lot of suspensions, a lot of liquids you have to deal with. What else could we use? Suppositories are a big one as well, right? So you use a lot of suppositories, especially for things like fever. You use a lot of acetaminophen suppositories. You can use things for especially constipation, lots of suppositories for that. So think about these other routes and what types of forms you have to put the drugs into. They can be that can be utilized. You have to consider a lot of things when you're looking at dosage forms, which we'll talk about a little bit later in more detail. And then so looking also at the kind of the sites for absorption, looking at the physiologic changes, which we'll talk about now. So first off, we'll look at gastric absorption for these Peds patients. So the main determinants for gastrointestinal absorption are going to be gastric acidity and also the gastric emptying time. And so this is going to be differing pretty greatly between your infants all the way up to your adults. If you had to imagine, especially in a newborn, so a kid in that first month of life, or let's say the first week of life, how do you feel like their gastric acidity would compare to an adult? The pH would be higher or lower? Should be higher, right? So they should be less acidic for the most part. And if you imagine a baby who's been in the womb for the past 9 months, what do you think they've been kind of swallowing the whole time? Amniotic fluid. And is that very acidic or basic? It's pretty neutral, right? So if you imagine, like, they are going to have a lot of, they don't, especially as they get more immature, they're not going to have a lot of gastric acid secretion. You're going to see the pH be higher because of that. And also the amniotic fluid kind of washes away any acid they are producing, making things pretty basic for the most part. So you'll see higher pHs, especially in preterm infants. So the younger or the earlier they come out, the less it's going to take longer for their GI tract to really kind of catch up and increase that acid secretion. And so higher the gestational age, the more gastric acid secretion they're going to have there. Usually the pH is going to be between something like 6 and 8 for the first few days. And again, that's due to the amniotic fluid they might have been swallowing during the gestation period. You end up seeing kind of the highest acid content for a term infant kind of start to develop during that first 1 to 10 days, and then that kind of starts to kind of pare back a little bit, and so kind of the second 2/3 of the month you start to see that acid secretion start to go down a little bit, and then they normally by 3 months or so they should be hitting pretty close to adult values as far as the acidity of the stomach. And so what this is going to do for drug absorption for us means that for acidic drugs, when they are in a more basic solution, it means they're going to have a higher ionization proportion, and which means they're going to have decreased absorption. So if I were to try to give a drug like aspirin, which is a weak acid, to that early stages of life, you'd have actually less absorption of that drug, right? And so less of it getting to systemic circulation. Whereas with something like basic drugs, they would end up having a decreased ionization, so it would actually have better absorption during that early time period. Bless you. So the other determinant we mentioned was that gastrointestinal emptying time, that GIT. So this will determine the rate of absorption. You'll end up seeing that, especially with the preterm kids, especially the younger ones, less than 6 months of age, it's going to be a lot slower in those infants when, as far as just the time for processing things through the GI tract. And so you can have lots of congenital malformations that can affect this as well. So especially if you have any kind of congenital heart disease, they might have impaired gastric blood flow, which will decrease that time, so that things will be kind of just sticking around for longer. Types of feeding they have, whether it be breast milk or formula, can have an effect here. And then also, obviously, the more well-developed they are, the better their gestational age, the kind of faster that gastric emptying time is going to get. Okay. So shorter transit time, meaning they're kind of pumping things through quicker, is going to decrease the duration that the drug is actually going to have contact with the absorptive surfaces within the intestines, and so that's going to decrease the total absorption you're going to have there. So they're kind of just spitting everything through very quickly. They're not really going to have a lot of time to absorb things, and so you find things like extended release formulations may have incomplete absorption, right? Because they're just going to get sent out too quickly, which is why we don't use a lot of extended release formulations for kids in the first place. But this may account for why, if you're doing something like serum levels of different drugs for especially young kids, you may see actual big differences in how much they're really absorbing. So even though you get the same dose to 2 kids who have the same equivalent weight, they may have actually different blood levels. Okay. So just to look at extraoral drug absorption, some other ways that these kids can be absorbing this stuff. Hopefully this won't be picked up on the recording, but we'll see. So looking at different things like, more parenteral absorption of drugs, so things that are not going by the oral route. For muscular blood flow, you'll actually see that for the most part it's very reduced in neonates, especially in those underdeveloped ones. As you might imagine, blood flow preferentially likes to go to what places? The head and the heart, right? So the brain and the heart like to keep things kind of going to the most essential organs first. And so the muscles are not really well perfused in some cases, or can be kind of erratic in a lot of cases. And so especially with kind of underdeveloped neonates, you see they have issues like temperature regulation as well, because they can't really regulate that blood flow super well. As they start to get a little bit older, you're going to see increased muscular blood flow, and then by the time they're children, toddlers and whatnot, they should have pretty close to adult values. And so, how do you think that might affect drug absorption? Just the muscular blood flow.
Patches won't be as effective.
So we'll talk about transdermal drug absorption, but just strictly, so obviously I'm talking about muscular blood flows, I'm talking about intramuscular injections. How do you think it might affect it? It'll be slower, right? It's going to be erratic as well. It's kind of the other thing you see. So you're going to have erratic absorption of drugs that are being administered in an intramuscular route, okay? Just because that blood flow is kind of not well regulated for the most part. Looking at mucosal permeability, you end up seeing, and this kind of goes along with the skin permeability, they are much thinner than you would see in adult patients, so things are going to have an easier time crossing a lot of those biologic membranes, right? So mucosal skin permeability is going to be increased, and then by the time they're children, it should be, as that integumentary system kind of gets more developed, they are going to have closer to adult kind of rates of absorption. So you can run into issues where kids, especially very young, if they get applied a bunch of creams and things like that, they can actually have pretty significant absorption. Good example of that, there was a case out, and I believe it was California or somewhere, where moms were, giving birth in the hospital, and they were applying moisturizer to the babies, and it was like a particular brand of Aveeno or something like that. And then they did, for certain probably high-risk patients, they were actually doing urine drug screens on the babies to see if the mom had been exposed to anything, prior to the birth. And these kids were coming back positive for THC, which is in marijuana, right? So they're testing positive for THC, and the mom's like, I've never smoked pot in my life, and they're threatening to take babies away and stuff like that. What they actually ended up finding was that the moisturizer they were using had a component in it which actually tripped the assay for THC in the urine drug screens. Because the baby's skin was so thin, it was able to cross very easily, and so they could get this product eliminated in the urine. And so once they kind of figured that out and what was going on, then they were saying, okay, well, obviously this is not going to be super useful, maybe switch moisturizers or something like that.
Does hemp product, is that kind of...
I'm not sure if that would test positive or not. It would probably depend on the assay that you're dealing with and the specific product. But whatever reason, it's Aveeno that was used in the hospital, so it's probably not necessarily hemp based, but it was probably had some component of it that looks similar enough to the assay that it said, hey, this is THC, even though it really wasn't. So again, skin absorption is going to be very, very well. It can lead to a lot of toxicity if you're not careful in some cases. So I mentioned with the intramuscular absorption, again, this will be dependent on the blood perfusion to the area of injection. So they're not really getting good perfusion. You're not going to get really good absorption from that standpoint. And then the rate of drug penetration through the capillaries can be affected by this as well. Okay. You're going to see the apparent volume into which the drug has been distributed can change as well, because we mentioned, especially very young kids, they have a high water content, especially compared to like an adult. So I mentioned, the big bag of water comparison is kind of apt because they are just so full of water, the water content is so high that it's going to be affecting the volume of distribution, especially for hydrophilic drugs. And so that can be playing a role when you inject it into the intramuscular space. So neonates and infants are going to differ from those older children because they have decreased blood flow, higher percentage of water in the muscles, so higher apparent volume of distribution for more hydrophilic meds. They're going to have a decreased extent of muscular contractions, right? And so as you have more muscular contractions, you have more blood flow. That should aid absorption, but if they're not really moving around a whole lot, you're not going to see that there. And then that peripheral vasomotor instability, because they can't regulate temperature, that's going to affect the blood flow additionally. So intramuscular injections for especially very young children can be difficult just because you don't know really how well they're going to absorb it. So looking at the rectal absorption, obviously you mentioned the mucosal permeability is going to be pretty high for in the kind of neonatal infant time period. So you actually see increased bioavailability of some medications, which means you're going to have increased mucosal translocation of drug, and so that's why we use a lot of suppositories and things like that, because they do get really good absorption of like acetaminophen and drugs like that. You do have to worry about increased amplitude of rectal contractions, which means what could happen? You got to push it right back out, right? So if the drug's not sitting there in the rectum, it's not going to get absorbed. It's not going to do a whole lot of good. So that is one thing you may need to consider, like redosing patients if they end up spitting it out too early, right? I guess they're not really spitting it out, but if it comes out too early, then yeah, that reverse spit maybe, I don't know. The other thing to consider, another way we can get drugs into our patients would be through the intraosseous route. The bones are nice because they are basically non-collapsible veins, and so as I've kind of alluded to previously, pediatrics, when you're dealing with getting an IV, especially if you had like a neonate or say you have like a septic child, something like that, how easy is it to get an IV? Not easy, right? So, I mean, there's some kids who you will just not be able to get an IV on unless you would have like an interventionalist come in and actually like be able to you know, do some kind of like IR guided kind of procedure. But for the most part, you're going to find that it's more difficult than you would see for an adult. We have lots of tools that can kind of help us. You guys ever heard like the WeSight? There's lots of different products that do it, but you basically use like infrared light. You can actually shine it onto like the arm or different places, and it actually lights up where the veins are at, which is kind of cool. So lots of little tools that you can use to kind of help get IV access for kids. But kind of the easiest thing you can do is get intraosseous absorption. So basically you just put an IO in. Most kits kind of come with like a little power drill, which is kind of terrifying, but does not really, I hear it does not hurt very much. I don't want to try it, but that's what I hear. But because kids end up having kind of a soft outer cortex because their bones, especially the long bones, aren't super well developed yet, they do have easy access to that space, and you have rich kind of vascular flow through the marrow. So it's going to be very useful, especially in emergent situations. So if we have a kid who's coming in, they are coding, we need IV access right now, and IO is going to get placed, right? Do you guys know where the different places you can put an IO are?
Tibia.
The tibia? Sternum. I'm seeing like the humerus can be used. I don't know about the hip. That might be, I'm not sure. Any paramedics here? Yeah. So, yeah. So I think those are the kind of the three main places. But usually you end up using tibia probably as the most common one, especially for pediatrics, just because it's kind of easy of access to get to. But one horrifying thing I saw one time when I was in the emergency department, we had an adult patient who was a code red. So cardiac arrest was coming in, and they couldn't get IV access, so they ended up doing an IO for the patient. But patient unfortunately ended up not making it, but they're trying to remove the IO, and typically it looks like a giant push pin. Basically, we have like the needle, and it looks like a big like kind of plastic end on it, and so the plastic end ended up coming off of it as they tried to remove it, and so you just had like a big needle kind of sticking on this guy's tibia. It was pretty terrifying, but most of the time they work pretty well, so don't let that scare you. Okay, anyway, so then looking at percutaneous absorption, so transdermal absorption of drugs here, we mentioned that kids are going to have an underdeveloped stratum corneum, which means that the kind of the thickness of that stratum corneum is inversely related to absorption. So the thinner it is, the better my absorption is going to be for drugs. This has led to toxicity. So for instance, if you were to use something like betadine, which has a high amount of iodine in it, as you might imagine, you can actually cause hypothyroidism in some of these kids. That's one of the reasons why you don't use betadine in infants, right? Because you have overabsorption. Too much iodine can actually shut down the thyroid gland and can lead to some issues. I had one case when I was in fellowship. We actually had, I know I've probably mentioned this before, but there was a young child who was having a lot of diaper rash, and I guess the dad was a chronic pain patient, so he had this like specially compounded cream that had like amitriptyline in it and ketamine and all kinds of other products, and we ended up, the mom applied it to the baby's diaper rash right after a bath, and then closed up the diaper. So what are some problems with that you might imagine? Heat, right? Moisture. But you're occluding the skin, right? So anytime you put an occlusion over dermal application of a drug, you're going to have better absorption there. And also the babies right after a bath, so they're nice and a lot of good blood flow to the skin. So the kid ended up absorbing like a ton of that drug, and ended up becoming apneic. Got transported into to the emergency department, where the kid actually did really well. But you could actually measure metabolites of ketamine in the bloodstream afterwards. So you could tell there's really good absorption the kid had from just that that kind of underdeveloped stratum corneum. So be very careful with dermal application of drugs for these kids. Other thing is like it's really well hydrated skin, so it's going to help to increase perfusion, especially if you have good hydrophilic medications and you have a harder time crossing otherwise. And then also looking at their body surface area, they have a lot higher BSA compared to their body mass than an adult might. So even though you're applying it to a small area of skin, it's relatively much larger than you'd see for an adult, so you're going to get better absorption there. So be very careful there. You can see issues with antihistamine lotion. So if you were to put like calamine lotion on the kid that had like Benadryl on it or in it, that would lead to anticholinergic toxicity. There's a seizure seen from that. Even using things like isopropanol, which you guys know another name for isopropanol. Rubbing alcohol, right? So isopropyl alcohol. You had good absorption of that in some kids, which actually led to hypoglycemia. So again, be very careful. They're going to absorb stuff much better than you would see with older kids or adults. So then looking at the distribution, so once the drug has been absorbed, where does it go from there? And so you're going to see that the, you guys remember that the volume distribution can be calculated based on the dose of the drug that you're administering divided by that initial concentration, right? So knowing those three factors, or knowing two of them, you can kind of figure out the third one. And again, we know that this is not really kind of a hard and fast number. It's more of kind of a representative number to kind of tell us how far this tissue distribution is going to be for these different drugs, right? So kind of how big is the bucket we're trying to fill for these patients. So you can look at the distribution, looking at things like total body water, how that's going to be developing as the child starts to get older, and then looking at body fat and extracellular water. So you can see how those kind of change. Notice how the high total body water content is going to start to kind of drop and level off as they get around to be 6 months of age, whereas the fat content is going to start to increase as well. Okay. So they might have a nice little cute chubby baby. They may not actually have that much adipose tissue. It could be a lot of water that they're holding on to as well. So general other factors are going to be affecting this. The lipid solubility of the medication. More lipophilic drugs are going to be partitioning more into the adipose tissue. So if they have less adipose tissue, you might have a lower volume distribution for them. What do you think plasma protein binding does to volume distribution? Increase or decrease it?
Reduces availability.
Yeah, decreases, right? Because if it's all being held in the central circulation in the bloodstream, by those proteins, it's going to limit and lower your volume distribution as well, right? So you can run into issues. We'll talk about protein binding as well. We already mentioned some issues with that in the neurology section. Tissue binding can affect this. So if I have high tissue binding of a drug, what does that do to VD? Increase it, right, because more of it is being bound out into the tissue. Perfect. And then again, just looking at that peripheral tissue distribution based on the adipose tissue and the water stores of the patient. You're going to be seeing that the disease states can affect the volume distribution. So if you were to have kids who have a significant edema, say they have poor circulation due to congenital heart malformation or something, that can lead to changes. Burn victims, things like that, all of that can be affecting their VD. So again, keep in mind this can be changing based on the disease state of your patient as well. So looking at the newborn infant, around 70 to 75% of their body weight is going to be made up of water, and they typically have a higher extracellular water component than you see in the adult. So around 40% extracellular fluid versus just a 20% in the adult. They have less fat tissue, they're going to have less muscle tissue. So all that means for hydrophilic meds, you're going to have a higher volume of distribution, which is important when you think about things like neonatal sepsis. We're going to give a lot of hydrophilic medications like aminoglycosides. That can be affecting how you're going to be dosing those drugs for those patients based on things like gestational age and whatnot. So again, just keep in mind, in order to achieve the same concentration as you would an adult. So again, if I had a, say a 2-year-old, or let's go even younger, say like a 6-month-old versus an adult patient, and I was to give a hydrophilic medication, how would that dose compare between the kid to the adult? So the kid dose would be bigger or lower to get the same concentration? It would have to be higher, right? Because with kids having a higher water content, I have to give more drug to fill that space to get the same concentration. Okay, I'll show you some comparative examples in just a minute, but basically for hydrophilic meds, you have to give larger doses to kids in order to achieve the same concentrations as you would for an adult, right? So especially for things we're doing therapeutic drug monitoring on, like aminoglycosides, that can be important because you want to make sure you're getting high enough levels to make sure you're treating the infection without causing toxicity. So, as an example, gentamicin is probably the most common aminoglycoside you're going to be giving to Peds patients. If you look at the volume of distribution on a liter per kilogram basis, which is usually how this is going to be expressed, you can see how this differs. So it's much higher, say 0.5 to 0.6 liters per kilo versus something like 0.2 to 0.3 for adolescents and adults. Okay, so then compare that to your dosing. You can see that for those neonates, 4 to 5 milligrams per kilogram per dose will give you the same serum concentrations, because again, they're going to have a higher amount of water for that drug to partition out to, then your adults may only need 1 to 2 milligrams per kilogram. Okay, both of those doses in those individual patients will end up achieving the same serum concentrations. Okay, so kids have a bigger bucket to fill, so you may need to give more drug. This is applying specifically to hydrophilic meds. Does that make sense? Okay. The other thing you're going to run into, especially with especially preterm kids, are going to be decreased plasma proteins, which means if you have drugs that have a high proportion of the drug is being tissue bound or is being protein bound normally, and if I have less serum proteins, what does that do to my volume distribution? should increase it, right? Because not as much of it being kind of sequestered in the bloodstream is going to be able to partition out more. You can also have issues where you have drugs that will compete for binding as well. So especially early on, you can have issues with bilirubin. Kids with jaundice and things like that can high bilirubin concentrations can displace a lot of drugs. And there's actually some cases where like you don't want to use certain drugs during that first month of life because you can actually displace that bilirubin. Does anyone know what drug that might be? It's an antibiotic. Don't want to use it in the first month of life. It's a cephalosporin. A third-generation cephalosporin. Ceftriaxone, yeah, you don't want to use ceftriaxone in the first month of life because that can actually displace bilirubin and cause jaundice in those kids. So that's why we use cefotaxime or clafuran as kind of like your third-generation cephalosporin of choice, right? So another consideration you have to make based on the age of your patient and kind of what you're dealing with. Another good example would be phenytoin. Obviously, we use that for what? For seizures, right? So again, epilepsy it's a big thing. You're going to see in a lot of these kids who are coming to the emergency departments and things like that. You're going to find that when we looked at that, kind of what percentage of phenytoin was bound to serum proteins? Was it a lot or a little? It was a lot. It was around 90%. Remember when we were looking at levels of phenytoin, a total level of 10 to 20 mics per ml was the therapeutic concentration. The corresponding free level was something like 1 to 2 mics per ml. Right, so keep that kind of in mind, but it's a high protein binding proportion. So as you decrease the amount of proteins the kids have, what does that do to your free fraction of drug? It's going to go up, which means that even though they may have the same total level or a therapeutic total level, because they have less proteins there, they might actually have a higher free fraction, and thus they may be more prone to toxicity. Okay, so all things you need to consider when dealing with these patients. So even though you have a kid who is on the right dose and their total level looks good, they're kind of stumbling around, they look like they're drunk. Obviously, you need to consider the fact that maybe their serum proteins are not really up to snuff to bind up all that phenytoin. And in which case, what would you do?
Reduce the dose.
Well, if you had a therapeutic total level and the kid's toxic,
Is there an antidote?
no antidote. Check a free level, right? You always want to check a free level to make sure there's not anything else going on, but make sure that's actually what the case is. So again, the total level, say 15, but then the kid's free level came back at 3, then you would know that, okay, well, this is obviously probably an issue with the protein binding. Maybe I can reduce my dose to fix this or switch to something else or whatever you have to do. You can keep that in mind with phenytoin. You always want to check a free level. Things don't really make sense based on what you're seeing. Okay, so again, just looking at things like plasma albumin and all these different proteins, you can see how these things are going to be changing. Some of them are going to be increased in the neonate. Some of them are going to be decreased. So things like serum bilirubin obviously is going to be increased in the neonate, which will kind of normalize out pretty quickly, especially during that first month of life or so. Plasma albumin would be another big one. So mainly these changes are going to be affecting the neonates for the most part. And you can keep in mind that a lot of your dosing for drugs have already taken this into account, which is why the dosing is so different, which is why you should always look this stuff up prior to prescribing. Okay, so that's it for distribution. Then moving on to the metabolism of drugs in these kids. Yes?
So we have to adjust for more like obese pediatric patients if they have a higher fat content.
Yes, that is something you have to consider. So I don't really delve into it too much for you guys, since it's kind of not something you need to know like specifically for kind of clinical practice. But there's this idea of kind of an adjusted body weight that we'll use. So obviously you have the patient's total body weight, right, which is what they weigh, and then you have like an ideal body weight based on the height of the patient. So we do this for adults as well. If you're dealing with like 400 or 500 pound patient who's in the ICU, like obviously you can't give them the full kind of mg per kilo dosing as you would for a smaller patient, because you end up overdosing them, right? Just because that they don't partition out to all the adipose tissue. So those patients, we use what we call an adjusted body weight, which is kind of the middle ground between their ideal and their total body weight, and that kind of gives us a good kind of idea of what we should be dosing them at. So sometimes for really obese kids, we might use that adjusted body weight. It just depends on the situation. For really highly lipophilic drugs that have a high volume distribution for all that fat tissue, then we might still use the total body weight. Whereas something more hydrophilic, where they wouldn't have distribution to all that tissue, we might use an adjusted body weight. Yep. Okay, so things will be affecting metabolism of drugs within the small child. Will be including their gestational age and their postnatal age. We'll be looking at changes in hepatic blood flow. Can be important as well. Just the size of the liver usually with small kids, kind of what's their relative size of the liver compared to their body weight? Pretty big, right? So it's usually a lot larger than you see with an adult on a relative size, which is why in some cases you may actually see that kids are going to be more resistant to toxicity based on the fact they just have more liver tissue for their body weight. So for instance, if you were to look at, like, say, a toxic dose of acetaminophen for an adult, something like 150 mg per kilo might be toxic for an adult, whereas something like 200 is going to be the toxic level for a child, just because they have a lot higher certain enzymes are going to be in a higher proportion. Some of them obviously are going to be lower proportion, but just the size of the liver is a lot bigger, which kind of gives them some kind of built-in insurance, so to speak. You'll see that different disease states, so things like you have liver issues that can be affecting the metabolism, and then looking at enzyme induction and inhibition. So I mentioned a lot of kids with epilepsy, and what do a lot of anti-epileptics do? Well, they can cause seizures. They're high doses, but what can they do to the hepatic enzymes? Some induce, some inhibit. Like, remember, go back and kind of review that stuff, because you're going to see lots of drug interactions based on that. So again, this is why we like Kepro so much for kids, because you really lose out on a lot of those metabolism interactions. That's why it's such a good one to see for a lot of these kids. So going back, you guys remember there's phase 1 reactions and there's phase 2 reactions. You guys remember the difference between the two?
The way it's eliminated, the race it is.
No, that's first order and zero order kinetics. So you guys remember in the liver, we have phase 1 reactions, we have phase 2 reactions, which are going to be ultimately trying to get things more soluble, more polar, so that way it can be eliminated in the kidneys, right? That's kind of the ultimate goal of liver metabolism. Phase 1 reactions are going to be something where we are basically changing it. Usually we're going to be adding like a sulfur group or hydroxyl group or something in order to make it more water soluble, okay? That way it can be excreted by either the kidneys, the lungs, the bile, whatever it happens to be. Does everything that undergoes phase 1 reaction have to go to a phase 2 reaction? No, right? Some things can just go straight to being eliminated. Some things may not go phase 1 reactions, may just go straight to phase 2. But as you might remember, there's a couple of different specific examples. We mentioned things like oxidation, reduction, hydrolysis. All of these can be examples of phase 1 reactions. And the most important enzyme system here is going to be what? Cytochrome P450, right? So this is where this comes into play. So again, this is the most important pathway. Like, a ton of drugs that we're going to have are going to be metabolized through this pathway, and you end up seeing that even with a full-term infant, their activity of all the different enzymes is going to be about half of what you would see with an adult. Okay, you're going to find that the different enzymes will mature at different rates, which is why the drug dosing is going to change based on how old the child is, based on how well developed those liver enzymes are going to be. So, for example, if you're looking at oxidation of something like phenytoin, by 1 year of age, you can actually find that they have an increased ability to metabolize this drug compared to an adult. So they have maybe 2 to 5 times the metabolizing capacity for phenytoin than an adult might. They can just chew through it much more quickly because they will have upregulation of some of those enzymes until it kind of stabilizes out as they get older. Other examples, things that might be decreased, you might have examples, things like procaine and tetracaine, which are what types of drugs? You guys know? Yeah, local anesthetics. So you can have actual cases of toxicity if you have too high levels, because the drug doesn't get metabolized as quickly, because things like plasma esterases are not going to be kind of well developed in that time frame, right? Or very early on, at least. Things like theophylline can also be affected. Theophylline we would use for what disease state? Well, COPD, but we don't have a lot of one-year-old smokers, right? Yeah, so sometimes we'll use it for asthma, especially with like status asthmaticus. You may see this being used. The IV form or aminophylline can be used sometimes for really severe kids to try to kind of bronchodilate them, but the metabolism can be altered as well, where they might not be metabolizing quite so quickly. Just imagine like a little baby smoking, and just kind of made me laugh. So anyway, so specifically with CYP450, so the enzymes will mature at kind of different rates based on which specific enzyme you're talking about. So for example, you will see that something like CYP2E1, does anyone know anything good that gets metabolized by CYP2E1? Probably not. Alcohol is a good example of one that gets metabolized by that. Acetaminophen is going to be another one that gets metabolized by 2E1. That actually has increased activity pretty rapidly. Things like 2D6, which are really important for a lot of heart medications, a lot of neuro medications, will be detectable kind of soon after that. But you may not have a ton of the 2C enzymes or 3A4. They won't really be present until, like, say, the first month of life, right? So if I'm giving something that is metabolized by CYP3A4 earlier than that, you're going to see decreased metabolism, take longer for them to actually clear that drug. Okay, but you may see, after that time period, they may actually have elevated levels compared to an adult. So you kind of see these things where it'll kind of start out very low. As they start to mature a little bit, it'll kind of peak up above adult levels and then kind of flatten back out. So again, all of this is going to be enzyme dependent. All this has been kind of taken into account based on the drug dosing references you'll kind of go back to. So then the phase 2 reaction. So again, the other ones were kind of making things more polar, usually removing something from the molecule. Here with phase 2, this is where we're adding something on board, right? So this is where we can add a sulfur group, we can add a methyl group, glucuronide or glycine conjugation. All these things will make the molecule more soluble as well. It allow for kidney excretion for the most part. So things like sulfation are really important for acetaminophen metabolism. They actually have very well-developed functional pathway at birth, which also makes kids very, very resistant to acetaminophen toxicity, which is a good thing because, again, what's a common med that's in most people's medicine cabinets? Acetaminophen, and they, back in my day, their medication, it makes me sound like an old man. Rightly so, but the medicine used to taste really bad, but nowadays it's like actually tastes pretty good. Orange flavor, grape flavor, all that kind of good stuff. So kids like, oh, that tastes really good. Last time I was sick, let me drink all of this. So it's not uncommon to have cases of that where they will drink entire bottles of this stuff, but they're relatively well protected for the most part. Things like methylation for epinephrine is very well developed. You don't really see a ton of drug metabolism through this pathway, but different things will be metabolizing at different rates. For example, morphine actually is really underdeveloped, so it may actually have longer half-lives for things like morphine, until kind of the 3 years of age or so the drug will stick around for longer. So just different examples. There's another good one with glycine conjugation with benzyl alcohol, because benzyl alcohol is used as a preservative, but basically you cannot give this to infants because they can't process it very well, and so you get this kind of the gray baby syndrome that happens from that. So benzyl alcohol is one of the big things you avoid in neonates, which is why you have to use preservative-free products. So that's a very important consideration when giving drugs, especially IV, to these neonates. It has to be preservative-free, cannot contain any kind of benzyl alcohol. Moving on to excretion of these drugs. So again, renal excretion is going to be the main thing we're going to be talking about here, and so this is going to be dependent on obviously the number of glomeruli that they're going to have functioning, the size and the quantity of them. This is going to be affected very much by their gestational age, where very premature kids are going to have poor ability to excrete a lot of drugs through the kidneys. Obviously, protein binding is going to make renal excretion easier or harder? Harder, right? Because it's bounded by proteins, it can't really be kicked out to the kidneys so easily. Renal blood flow is going to be important, especially with your congenital heart malformations and things like that. And then looking at their disease states, other nephrotoxic meds that can also decrease kidney function. And then just going back to looking at absorption, looking at the pH and pKa of the drug, same thing applies to the kidneys, where things that are put in a charged state tend to be eliminated much more quickly through the kidneys because they can't be reabsorbed as well, whereas things that are more polar, less charged state, you're going to have things be reabsorbed, and so that can prolong the half-life of drugs. Okay. So looking at the GFR, glomerular filtration rate for these kids, you're going to see that initially the serum creatinine for these kids is going to be elevated for that first week. Do you guys know why that is? So during that first week, whose serum creatinine are you measuring? Mom's, right. So you're actually going to get a falsely elevated serum creatinine that you're going to be measuring because you're basically measuring what's left over from mom. So as that gets processed out and eliminated, you'll kind of get back down to what the kid's baseline is, right? So it's not uncommon. You might see a 1 week old has a serum creatinine pushing 1. Which would be very high for a true level for a neonate, but as that will start to dissipate as you get a little bit older, and then you're kind of measuring what their actual serum creatinine is. And then during that first 1 to 2 weeks of life, you're going to see further maturation of the kidneys there. We very infrequently, there's not really a good calculation that we use for calculating GFR for neonates, and so what else can we measure that kind of gives us a good idea of kidney blood flow and renal function for a neonate? Urine output. Urine output is going to be the biggest thing you're going to be measuring for these kids. You kind of want to look at urine output for kind of all your pediatric patients for the most part, just to make sure things are flowing appropriately. So for instance, if you're looking at, say, 1 ml per kilo per hour is generally going to be a pretty good value. Like for an adult, 0.5 to 1 is usually considered good urine output, but for a kid, it's not uncommon. Especially, kid comes out, I mentioned they're big bags of water. They end up having kind of a diuresis phase, especially in the first couple of days of life. So that's why you end up seeing those kids drop weight, right, because they're diuresing a lot. So you can see, you know, 3, 4, 5 mLs per kilo per hour for some of these kids early on, and so that is a good sign of the kidneys working. They're flushing out a lot of extra water and whatnot. So that's something you'll see, and they'll kind of dip back down towards kind of with their normal kind of baseline. So usually 1 ml per kilo per hour is kind of a good rule of thumb for good urine output for these kids. So,
do they measure the weigh the diapers, or they?
Yeah, so they can measure the diapers. Sometimes you'll have caths that will be in place, and they can just measure it directly from that. Obviously, this gets to be very difficult when you're dealing with adolescents. So, for instance, some of our CF kids, we're giving them a lot of nephrotoxic medications. We want to make sure the kidneys are working great. Telling a teenager that I need you to pee in this cup every single time so we can measure it, how often are they compliant with that? Not often, right? So they'll either be absent-minded and just pee and just, you know, flush it, or, you know, not really think about it, or just be defiant because they're teenagers and they can. So you can really run into a lot of issues where we're trying to track, especially from the pharmacy standpoint, because we're not really with the patient. We're just like, hey, nurse, we need you to really like measure this urine output so we can tell if their kidneys are working right. And the nurse is like, I can't do anything with this kid. So sometimes you have some difficulties you can run into from that standpoint. But especially with the preterm kids, they will have a relative decreased GFR compared to a term infant, just due to the fact they're going to have more immature and decreased quantity of glomeruli. They will have kind of these immature proximal tubules, which are important for reabsorption or excretion of products, and then just renal blood flow is going to be reduced in general. So it will take some time for their kidney function to kind of process and get better. That's why you will see things for, you know, gestational age less than 32 weeks. You're going to dose them you know, less frequently or smaller doses versus their greater than 32 weeks gestation. Then you'll see, you know, higher doses or more frequent dosing. Okay, so that'll be really important to consider for your patients. So just to give you an example, looking at kind of what their GFR is going to be doing. So again, term infants being that green bar, preterm being you know, say less than 2 kilograms there, and then like the really preterm kids, you know, so say something like, you know, so in the 20 weeks range, you know, say less than 1,500 grams. And notice, you know, you do a lot of gram measuring for all of these very small kids. You don't necessarily do kilograms as they get older, but notice just how you're going to have much decreased GFR based on the maturity at which they were born, but all of their GFR is going to be increasing as the kidneys start to continue to mature. But even, you know, something like, you know, 2 weeks after birth, you know, the preterm kids are not really even keeping up with what the term kids were at the time of birth. Okay, so they can take a while before they're really kind of normalized out to get to a normal kind of creatinine or GFR like you would see for a term kid. So keep the buns in the oven for as long as you can, right? Okay, and again, just if you were looking at actual GFR calculations, again, we don't have a good calculation for, especially in the neonatal period. For older kids, as they get a little bit older, we actually use, do you guys remember the calculation we used to get GFR for adults? But it has a specific name. It's like 2 guys' names. There's Cockcroft-Gault, remember? That's the GFR calculation you're using a lot in adults, and, you know, taking into account like their age and their weight, and you know, whether or not it's a female or not, because, you know, females have less or more creatinine than guys do. Usually less, right? Because in general, you're going to have less muscle mass for the females. But we actually have something we call the Schwartz equation. That's typically what we use to get GFR for pediatric patients. So again, make sure you're using the right calculation when doing GFR, because you can get wildly different results based on that. So Cockcroft-Gault is made for, you know, adult type patients. You know, we might use it for an adolescent who's getting adult size, but for these younger kids, you know, that Schwartz equation is going to be the big thing that we use a lot. And oftentimes, you'd end up seeing that they actually have like a constant. Again, a lot of these calculations are made based off of kind of big studies that they do. So they say, okay, well, if we, you know, measure all these different people and their GFR in a very objective manner, and, you know, what's a calculation that we can make to kind of predict this? And so, you know, they do a different one for kids, obviously, and so they would have a different constant based on the age of the kid and things like that, based on the maturity of their kidneys. But anyway, so looking at comparative GFR for these kids, so obviously the younger they are, the lower it's going to be until it kind of normalizes out. You know, at around, you know, 6 months and older, typically they're going to have pretty normal GFR. So just looking at an example here being, gentamicin, we said it's a very hydrophilic medication, entirely eliminated through the kidneys. Looking at the actual half-life of the drug, you can see how this will differ based on looking at the age of your patient, right? So something like a neonate who's less than 1 week old, notice how the half-life can range pretty greatly. A lot of that's based on their gestational age and how mature their kidneys were at birth. It can range anywhere between 3 to 11.5 hours versus something like an adult patient may last anywhere between 1.5 to 3 hours. Okay, so just looking at that kind of functional maturation that occurs as they get older. So obviously, if we were to say dose gentamicin for a neonatal patient, how often do you think we'd dose it compared to like an adult? Yeah, less often, right? So again, you say may only give this drug, say, 1 time a day, versus where in adults you would traditionally give it, say, 3 times a day. Nowadays, we usually just do once a day dosing for gentamicin across the board. But back in the day, you used to do Q8-hour dosing for adults. Usually for these neonates, you may even give Q24, you may give Q36, you may even give Q48, depending on just how preterm the actual child was. Okay, so you have to take all that into account. Any questions from the first section here we talked about? Nothing. Okay. So continuing on with the kidney talk. So looking at tubular secretion and reabsorption, this is also very important for drug elimination. So things that are needing to be kicked out into the kidneys by secretion aren't happening. Obviously, you're going to have longer half-lives of things, or if drugs are getting kind of overly reabsorbed, that can also lead to longer half-lives as well. So again, all can lead to drug toxicity potentially. You'll find that both of these processes are going to be significantly reduced in that first year of life. And again, other things you have to concern yourselves with renal development is going to be that decreased blood flow, especially if they have any congenital issues leading to changes in blood flow. They may have inability to concentrate very well within the kidneys, especially if that process is not occurring well. And then also you may have issues with lower urinary pH values, which may lead to some drugs to be reabsorbed more readily or other ones to be kicked out more quickly, right? So if I have a lower pH value, so say a more acidic urine, and I'm trying to eliminate an acidic drug. So let's say aspirin is a good example because it's a weak acid. Is it going to be more ionized or less ionized? So weak acid and more acidic urine. It's going to be less ionized, right? Because remember, like dissolves like. So if I put a weak acid into a more acidic medium, it's going to be in a more uncharged type of state, right? Which means I'm going to have what occur? Does it just all get eliminated in the kidneys? No, you're going to have reabsorption occur, right? So if I have things that are not charged, they're going to get more easily reabsorbed, which is why if you ever have like an aspirin toxic patient, you can actually give them sodium bicarb, which will do what to the pH of the urine? Increases, should alkalize the urine, and that actually will put the aspirin in a more charged state, which leads to less of being reabsorbed, gets eliminated more quickly. Okay, that's called urinary alkalization when we do that for aspirin toxic patients. Sometimes you'll even do it for phenobarb as well. Phenobarb being what type of drug? Barbiturate, right? We use it for epilepsy, especially in kids, right? So that may be another case where you might see increased elimination of a drug based on changing the pH of the urine. So, and again, looking at kind of how kids are going to, they have a lot of diversity in drug responses. And so there could be a couple of different factors involved with this, right? So you can look at things like, obviously, the age of the child, which we're focusing on today, but also other diseases, just their physiology, even the hormone status of patients can affect how they respond to drugs. One of the big things we're going to be looking at is going to be, just right now, is looking at the pharmacogenetic factors of it, right? So looking at, and a lot of these are obviously going to be undiagnosed, especially in very young kids. As they come out, they may not be metabolizing drugs very well, may have deficiencies or overactive transporters of drugs, and even transcription factors can be affecting this as well. So pharmacogenetics is a huge thing in pediatrics, because when you have a kid who does not respond as you would expect based on the type of drug you're giving or based on the dose, some of it can be related back to the pharmacogenetics. And so what changes do they have? What kind of polymorphisms do they have in their genetics that lead them to not do well with this drug, or to do well with a drug? So one really good example of this would be codeine metabolism. Kind of mentioned this before, but codeine is metabolized by CYP2D6, converting codeine over to the active form, which is going to be morphine, right? Do you guys remember any patients who are hyperactive at metabolizing codeine?
The tonsil kids.
The tonsil kids, right? Not necessarily that they were the ones that had issues with it. It wasn't necessarily because they had hyperactive 2D6. Usually people there was some Mediterranean, but also like African descent. So you see a lot of African American patients have issues with overactive CYP2D6. Okay, so what we saw for those patients, and it kind of makes sense because if you see patients with sickle cell disease, usually it's what type of patient? African Americans, right? And so you see a lot of them being put on Tylenol number 3, which is Tylenol mixed with codeine. A lot of them did very well with that for their pain control, and that makes a lot of sense if you think back to the fact that they have a higher propensity to have a more active CYP2D6, so they were converting a higher proportion of that to morphine than say like a Caucasian patient would. Okay. The thing that was happening with these patients was the one we were talking about, the TNAs or the tonsillectomies and adenoidectomies. Obviously, they were already having an obstructive issue already, right? They had obstructive sleep apnea. You go to get that taken out, and then what does the throat like to do after surgery? It likes to swell up, right? So if all of a sudden you have a patient who's already kind of swollen, and then they are converting too much the codeine over to morphine, what does that do to your respiratory drive? Decreases it, right? So they weren't able to respond to the fact that they have a lot of CO2 building up because they weren't able to oxygenate very well. So that led to some deaths associated with that. There could also be issues of the mother receiving codeine having more exaggerated effects on the child, especially with breastfeeding and things like that. So because of that, they got the black box warning put on that drug. Right, so those patients who are ultra rapid metabolizing CYP2D6 were more likely to have those toxicities, and some people who had poor metabolizing CYP2D6 had diminished response. Okay, so big issues to consider. Always look up, there's not usually a lot of good testing that we can do for these. You kind of have to base it on their clinical response and how they do with the drug, either with toxicity or the actual efficacy of the drug. So one other thing to mention with that, I'm totally lost my mind. Anyway, all right. So looking at the age-based dosing regimen. So how should we actually dose drugs for pediatric patients? I kind of mentioned a few examples, but what's the best way to dose drugs for patients? Their peds by weight, right? So that's not the only way to do it. That's probably the best way to do it, as we'll talk about. But there are other regimens as well. So one way we can do this is with age-based dosing regimens. So you may see this with something like codeine being dosed based on, say, kids age 2 to 5 or 6 to 12. So based on that, it's trying to take into account their physiologic differences between as they increase in age, right? As their liver starts to mature, as their kidneys mature more, it tries to take into account also the fact that they're going to be getting heavier as they get older. This is easy to use, and a lot of people still will dose some drugs based on the age of the patient. They go, okay, they're 6, I know how much to give, right? A lot of old school guys will still, guys and gals will still dose based on that. The disadvantage of that is assuming that all kids are going to be maturing at the same rate, right? Also, this does not take into account the fact that if you have a particularly heavy kid or if you have a very light kid, depending on other disease states and other things like that, it doesn't take into account their weight, which could lead to over or underdosing in a lot of cases. Okay, so age-based dosing, you may see that out there in some references, usually not preferred for the most part. So the body weight dosing is probably going to be the most common one that you're going to see being used in clinical practice. So for example, looking at neonates and infants getting say 20 to 30 mg per kilo per day of something divided every 12 hours. Okay, you may see something. A lot of things will either be dosed in per day, right? So you know what they're going to get for a total day's worth, and then you can divide the dose based on how often they should be getting it. So for example, if I was going to get 90 mg per kilo per day of augmentin divided Q12, so you just take the kid's weight, multiply by that 90, and then divide that by half to get how much they get per dose. Okay, so that is a very common way of doing things. Usually as you start to get to adult patients, that's when you're going to get into more kind of just flat dosing. So, something like acetaminophen giving 500 milligrams every 6 hours or whatever. Again, you will be dosing that mg per kilo dosing up until the adult, and then you don't really want to go beyond that for the most part. Okay, this is the most common scheme being used, but you may miss those kids that have issues with med clearance. You may, especially for heavier kids, you may have issues with volume distribution changes. So there are some caveats with this, but for the majority of kids, you can get away with using mg per kilo dosing for the most part. Okay, this can become very problematic, especially if you are dealing with like computer order entry. Right? I had one example where normally something like fentanyl in a post-op setting is dosed, say, 1 microgram per kilogram per dose. Okay, And obviously the computer will throw up errors if you try to do that in like mics per kilo per day or something, you know, so there's some things you have to consider to make sure your units are correct. But I had one physician who was trying to order, basically the kid was, you know, 20 kilograms, and so his dose for fentanyl would have been 20 mics, right? And so he meant to enter 20 micrograms into the dose field, but what he accidentally entered was 20 mics per kilo per dose. I had to call him up and be like, do you really want 2 milligrams of fentanyl for this child? And he goes, no, I probably don't want that. But just be aware of those kind of transcription errors that can occur when you're going between flat milligram or microgram dosing to using the weight-based dosing. Make sure that those stay similar in your mind so that we don't get things mixed up. Because pediatric dosing errors are a huge deal. They're much more kind of sensitive population. You can easily kill someone if you screw some of this stuff up, okay? So keep that in mind. Be very careful when dealing with pediatrics. Once you kind of deal with it a lot, like you're kind of an old hat at it, and it's easy, but a lot of people are very intimidated kind of going into it just due to their kind of sensitive nature. Some of the disadvantages, as I mentioned, you can have under or overdosing, especially in overweight kids, and then, you know, obviously we're having an increased kind of incidence of obese kids, so this is going to be something just to be careful with in that risk group. The other thing you might see, especially if you deal with hemonc kids or kids who are getting cancer treatment, you will see body surface area being used pretty frequently. So for another example would be like corticotropin. You may see being used for some like stimulatory testing for certain endocrine conditions. This one would be used in, say, 150 milligrams per meter squared. Okay. The disadvantage of using body surface area is you need to make sure everyone's using a consistent calculation. There's actually quite a few different calculations out there for getting body surface area, and so make sure everyone's on the same page for that. That way the dosing will be consistent between patient to patient. Okay, it's a very precise way of doing it, but it's also kind of more labor intensive because you actually have to figure out what the BSA is and make sure you're dosing it appropriately based on that. This can be problematic because, especially if you are measuring the patients incorrectly. So, for instance, how easy is it to measure height in, say, like an infant versus like an older kid? They wiggle a lot. You may have issues trying to actually get a true height on those kids versus, you know, an older kid who can just kind of stand up and be compliant. That can be problematic, right? So make sure you have the right height, because height is going to be one of the major determinants of getting that BSA in addition to their weight. So keep that in mind as well. Okay, so looking at actual administration of drugs, how we get drugs into the patient, looking at obviously, you know, the IVs that we're giving. You have to be very careful and consider lots of different factors, more so than you would do with an adult. So for instance, the volume of drug that we're going to be giving. So how many actual mLs are we administering to that patient, right? Obviously, the smaller the kid, the more sensitive they're going to be to large volume shifts. So for the most part, you try to get as concentrated of a drug as possible when you're giving these drugs to patients, right? Because especially if you're dealing with, say, a 1,000 gram baby, very, very small peanut, and you try to give, say, something like, you know, 40 mLs of drug to that patient, that's going to be a lot of fluid for them, right? Versus, you know, say an adult patient, 40 mLs is not going to be anything to them. So keep that kind of in mind. The drug volumes have to be kind of conserved, and you don't want to fluid overload a lot of these patients. You may need to look at things like, you know, multiple drugs being given and their corresponding frequency. A lot of times, especially if you're dealing with kids that have, like, you know, metabolic conditions and you're worried about like electrolytes and whatnot, you have to consider all the sodium they're going to be getting in their fluids, right? Or all the sodium they're getting with the medications you're actually administering to them, because a lot of drugs go into NS, or normal saline for the most part. So that can be problematic. A lot of mechanical and technical problems that can come about because a lot of their IV access is very tenuous. You know, it's very easy to blow a vein or to not be able to get a vein in the first part. So sometimes you have to be kind of you have to be creative in the way that we can give drugs to patients. So in some cases, you know, you have a kid coming in for you know, nausea, vomiting, they look kind of dehydrated, you want to get them fluids in an IV. You know, if you can't get the IV, how do you get them fluids? You could do an IO, right? So that's always an easy way to get IV access, right?
Make them drink.
They can't drink, they're throwing up. They can't tolerate it. They really need IV fluids. One of the ways is a fancy word. It's called hypodermoclysis. Have you guys ever heard of this? It's basically the same way we give dogs fluids in the vet office. So essentially what you can actually do is you give a drug called Hylenex, which is basically just hyaluronidase, and you can inject that. Usually we'll do it between the shoulder blades, and that will actually break down some of the connective tissue. You're injecting this subcutaneously. That'll break down some of the connective tissue, and then you can actually infuse full, fluid boluses into these pediatric patients. They look like a big tumor on their back or something, but basically they can absorb all the fluids, and subcutaneously. So again, you have to be creative when dealing with some of these patients in order to get what you need into the patient, right? So things to consider.
What's the name of that drug?
It's called Hylenex, hyaluronidase, basically just a brand name for that one. Obviously, parents get a little concerned, like, you're going to do what with those fluids? Like, where are you going to be giving it to? It's like, don't worry, it'll be totally fine. But it works great, just like for animals, they do subcutaneous fluid, absorption all the time. You can do the same thing for people.
So, like, once you give it and it breaks down the tissue, and then you give all the meds, does it just, like...
Usually we don't do med administration, it's really just kind of fluids. Yeah, we just be giving fluids subcutaneously.
And it just, like, comes back together?
Yeah, it'll just naturally just kind of reabsorb itself. It'll just kind of get absorbed naturally, just kind of the passive absorption, and then they'll, get rid of that big humpback they got. Basically, you turn your patients into a camel. So, anyway, that is one way to do it. Other things you have to consider. So, especially if you're having to do things like therapeutic drug monitoring, obviously, very small patients, their blood volume is not super high, so you can actually cause anemia if you're getting too many lab draws. Okay, so this is why very frequently you have different pediatric tubes that you're drawing blood into. You want to make sure you're limiting how many blood draws you're getting, and especially when you're looking at like the timing of getting some of those. If you're doing like vancomycin or you're dealing with gentamicin, things like that, getting the trough times is important, right? Because you want to make sure you're actually measuring the drug at the right time to make sure they're clearing it appropriately. You may need to kind of do some creative work to try to make sure you're doing the blood draws all at the same time, so that way you're not making your patient anemic, basically. So other things to consider as well. Very frequently, we will use syringe pumps or some sort of pump device in order to infuse drugs into patients. So obviously, with an adult patient, you will, you can hang a bag of IV fluids and just let it go, right? If I hang a liter bag on an infant, that can be problematic, right? So you need to be very specific with the type of volumes that you're giving to make sure the patient does not get overdosed when you administer that. So, for instance, if there have been cases where someone's trying to, they hang a liter bag on an infant and they actually ended up getting pulmonary edema and dying based on the fluid overload. So you have to be very, very careful when doing this. And so we can use pumps to kind of help us prevent a lot of those issues from coming up. So here's an example. This is like the pump that we use over at Nemours. Basically, the big thing we use to make sure patients are getting the right dose, the right amount of fluid, is we have a lot of medication libraries we actually build into this. So for instance, we try to have standard concentrations for everything so that we can make everything the same way every time. The patient will have this hooked up and basically it'll be set to infuse a certain amount of volume over a particular set of time, all based on the library. So it makes sure, one, that we're giving the right concentration, the right dose of the drug based on the patient's weight, which is nice because you can put in, say, okay, here's the weight of the patient and here's the dose we want to give. If it exceeds that value, it can warn you and say, hey, you're giving too much, are you sure you want to do this, which is a nice safety feature. I think you might want to give some drugs too quickly, right? So if you can't just IV push every single med out there because you can lead to issues with like hypotension. You can have with fentanyl, you can see like chest wall rigidity where they can't really aerate very well after that. Phenytoin can lead to some bradycardia and hypotension. So this allows you to make sure you don't give drugs too quickly, right? So that can be another kind of big safety feature there. It's also nice because you can do like different libraries. We can have like, here's the ED kids, here's what they're going to be getting versus the ICU versus med surg, and hopefully prevent some med errors from that standpoint. So these are very, very useful. We use it very frequently in pediatric patients. And then going to oral administration, obviously this is a more common one, and this is what probably would be recommended to a lot of patients. Again, we mentioned a lot of meds that we're going to be giving are coming in what dosage form? Yeah, usually suspensions, solutions, liquids basically are what we're administering to our patients, right? If you give a big 800 milligram ibuprofen to a small child, they may or may not be able to do much with that, right? You'll be surprised. Some kids will be, especially if they take a lot of meds routinely, like they get very good at taking pills even at very young ages, but a lot of them will not, right? So I know some adults that still won't take pills, but you can give suspensions and other oral liquids to these patients. So the measuring devices are super important. So for instance, how did most of you guys get medication when you were a kid? Yeah, chewables, but how about the liquid? Teaspoon, right? Either a teaspoon or tablespoon, right, to be administered. So what's kind of some of the inherent problems with using that kind of measurement? Yeah, like I have like some from IKEA that are like super weird Swedish shaped, and I don't have any idea how much volume they have, versus I have like a grapefruit spoon that has, I don't know how much is in that one. There's a lot of intervariability in the actual spoons they're using, right? Do you guys know how much volume is in a teaspoon?
15
That's a tablespoon.
I don't know.
Teaspoon's 5 mLs, right? You guys are gonna be medical professionals, and almost no one knew that. So imagine like lay people. They don't know that, right? So nowadays, we don't really recommend dosing in tablespoons and teaspoons and whatnot, right? We all recommend dosing in milliliters, right? That's a really important thing. So obviously with milliliters dosing, how do we get that out of the bottle? Yeah, so oral syringes are becoming a lot more popular. So again, make sure patients have all the stuff they need to actually be able to dose that. And so it's so funny because like now that I have a kid, I can kind of experience it from the other side. But like one of the big things we always did at the pharmacy when we were dispensing oral suspensions and things like that for patients is that we put a little stopper into it that allowed you to put an oral syringe in. You can draw out your med. It made it really easy. We ended up getting a bottle of Tylenol for our kid. We had a syringe, but there's no stopper in it. So I'm just like, well, how the heck am I supposed to get this out? And ended up making a big mess and stuff. But you have to make it really convenient for the parents in order to make sure you're administering the right dose to the patient. So it can be very, very important to make sure you're dosing in milliliters. Make sure that they are provided with things like oral syringes so they can actually draw it up appropriately and give the right amount. Because teaspoons and tablespoons have led to lots of dosing errors, people not knowing the difference between the two or goofing up the dosing and giving way too much or too little. Okay, so that can be very problematic. You also look at the sensory appeal of certain dosage forms. So obviously, if you look at things like, Flintstones vitamins, kids get into those all the time, right? Because they look like candy, right? Or like gummy vitamins. I can't tell you how many calls I had at the poison center of like, oh, my kid ate 500 gummy vitamins. Are they going to die? And I go, no, they're not going to die. But if you make things look like candy, obviously they're going to go for it, right? So bottles of orange flavored ibuprofen get drank all the time, or cherry flavored Tylenol. So things are becoming much more appealing to kids in some cases, but you have to consider that, like what their taste preferences are. I never considered the fact that like cherry Tylenol is really gross, and so like all the nurses like, we have to have grape flavored Tylenol on the ED here. And I'm like, what's the big difference? It's like, this one's cheaper, just go for that one. No, you got to have the grape flavor. That's where it's at. Because if the kids are spitting it back out at you, you're going to be much more prone to try to get something that the kids actually like, right? And giving medications to kids can be very, very difficult from that standpoint. Other things to consider, drug-food interactions. So obviously kids have to eat, and so you have to look at things like, from giving them a fluoroquinolone or from giving them macrolide or something like that, are they drinking milk that can bind up with it? Are they taking other things that can potentially lead to less absorption of the drug? So consider those things. And then inactive ingredients can be another big thing to worry about. So one, looking at like dyes, right? So looking at the, if certain red dyes kids might have more propensity to be allergic to, you have to make sure you find things that have, things that are compatible with those patients. So, for instance, we carry dye-free Tylenol at Nemours because there are certain kids who have allergies and cannot receive dyes in their stuff. Other things you have to consider, did I ever mention the ketogenic diet? Mm-hmm. What is that?
No carbs.
Yeah, no carbs. So imagine a lot of these suspensions, what do we suspend a lot of these drugs into?
Sugar.
Lots of sugar, right? So you have to make sure that if you have a kid who has a ketogenic diet, you don't screw that up and cause seizures by giving them things that have too much sugar in it. So in a lot of those cases, we have to end up like crushing up tablets and suspending that in water and giving that to them. Okay, so always keep these different things and dosage forms in mind. When giving suspensions, what's a good education point for patients?
Shake it up.
Got to shake it up, right? So there's been cases where people do not shake it up, and then they get all the drug at the bottom, and they get really toxic towards the end of the month, and they don't really have any good effect towards the beginning of the month. So always make sure they shake it up good. Okay, so again, when you're prescribing, make sure that you attain the most current weight possible, right? There have been lots of cases where people do not update their weights. They're not taking into account the kid maybe has doubled in weight since the last time you've seen them, and you can goof up your dosing really bad doing that, okay? Make sure you're getting a current weight whenever possible, and always check with your available references. As I mentioned, Lexicomp is a good one. They have good pediatric, pediatric Lexicomp, which gives you lots of good dosing for that, especially for like neonates. You might have a reference called Neofax, which is really good for finding neonatal specific dosing. So check your references. And also, when you're counseling your patients and you're educating them, especially if you're doing it with the kids specifically, because obviously you want to empower them as much as you can based on kind of their development. So my 8-month-old would probably just blow raspberries at you if you tried to tell her about her medication. But, something like a teenager would be much different. And being able to speak kind of on their level, it can be really important and kind of help with compliance. So anyway, so the other big thing, and this will definitely be on the test, is figuring out drug dosing. Okay, so if I tell a parent I want you to give 500 milligrams of this suspension to your kid, what are they gonna say? Yeah, how many mLs is that? That's what they need to know, right? This is important for even like your nurses and things like that. So it's great that you can come up with a dose. Glad you can do that. But being able to come up with how much volume to actually administer to the patient is the critical point. If they can't figure that out, then they're not going to know how much to give. So you will be asked to calculate some dosage regimens on the test, right? And so it's important you guys, we'll go over a few practice examples on how to do that now. You'd be surprised how many people come out of school not knowing how to do this at all. Whether you be PAs, pharmacists, nurses, a lot of people do not ever get practice of this. So this is why we're doing it right now. Okay, so let's say for instance, and I don't actually have the answers in front of me, so I'm going to be calculating it with you, not checking my Twitter. Okay, I don't have Twitter. Okay, all right, so let's say for instance, and again, the other thing to always make sure your patients, you're dosing based off of kilograms, right? So it's great if you had the pounds, but always convert it back over to kilograms for drug dosing, okay? So how do you get from pounds to kilograms?
Divide by 2.2.
Divide by 2.2, right? So for every kilogram, that's 2.2 pounds. So divide pounds by 2.2 to get your kilograms. Okay. So let's say we have a 15 kilogram child. He has acute otitis media. Now we need to dose him with amoxicillin for this. Okay. So we're going to be giving him 90 milligrams per kilogram per day, and we're dividing that twice a day. So how much is he getting per dose? Should be in, 45 mg per kilo per dose. Okay, the suspension that we have comes as 400 milligrams per 5 mLs. This is very frequent. You're going to be seeing this due to that that kind of historic use of tablespoons and teaspoons, which 5 mLs is what? It's 1 teaspoon, right? Tablespoons 15 mLs, teaspoons 5 mLs. So how much should this child receive per dose? Okay, so how do we go about figuring that out? So first off, you figure out how many milligrams he's going to be getting per dose. So he's 15. We said we're going to multiply that by what? By 90. So we'll say 90 per day. So he's getting how much per day? Yes, 1,350 milligrams or 1,350 milligrams I should be getting. So we know that's given twice a day. So we're going to divide that by 2, right? So he's getting how much per dose?
670.
You guys should do this with me if you'd like to make sure you can do this on a test. Like, you know. Okay. All right, so he's getting 675 per dose. Okay. So how do I figure out how many mLs he's going to be getting per dose?
Divide by 400 times 5.
Right, so first off, it's always easiest if you get your drug, get that into milligrams per ml. Okay, that's what I always like to do first to make sure I can do everything on an ml basis. So I'm going to do 400 divided by 5. So that's how many milligrams per ml? 80. Okay, so then I take my, what do I do now? 675, right, because that's what he's getting per dose, and I divide that by 80, and that will give me 8.4 mLs. So the kid's going to be getting 8.4 mLs twice a day. So you have to make sure they have a dosing syringe so they can draw that up, right? Before you might have said, oh, give them a teaspoon and a half. Who knows how much a kid would actually get, right? Make sure you give them a dosing syringe, they can drop 8.4 mLs and give that twice a day. That makes sense so far. It's really easy, deceptively easy, but do it a few times. That way you get the practice with it. You can make up your own little test problems and stuff like that if you like. Okay, let's say for instance we are going to be actually no, I got the whole dose right there. That was really nice of me to include that. Anyway, right, so basically this is how you're going to end up getting the answer, so you guys can kind of go back through and get that 8.4 mLs per dose. Okay, let's say we have an 18 kilogram patient who needs ranitidine. You guys know the brand name for that? Zantac, right? We're giving it for some GERD symptoms, right? We'll talk about some GI stuff a little bit later and talk about that. But he's going to be getting 4 milligrams per kilogram per day. He's going to be getting that twice a day. Okay, so the syrup comes as a 15 milligram per ml concentration. So how much should they receive per dose? Okay, so I'm going to take my 18 kilograms and multiply that by. So 18 times 4, so he gets 72 milligrams. Now what do? Remember, divide by 2, otherwise you'd be getting double dosed. If you just get that, and that 72 milligrams gave that per dose. Remember to divide by 2. So he's getting how much per dose? 36, and then you divide by 15. So divide by 15, and boom, you got 2.4 mLs he's getting per dose. Pretty straightforward. Okay, let's say we are giving a patient who's got cellulitis, we want to give him some trimethoprim sulfamethoxazole. Do you guys know the brand name for that? Bactrim, yep. So we're going to give some Bactrim for this, 12 kilograms. And this is an interesting one. You will see with some drugs, you will actually dose based off of a specific component. So for instance, with trimethoprim sulfamethoxazole or Bactrim, you dose based off the trimethoprim component. So if you look in drug dosing, you'll see like 4 milligrams of TMP, the trimethoprim, per kilo per dose. Okay, and then when you're looking at the drug, you see, okay, it comes as sulfamethoxazole 200 milligrams and trimethoprim 40 milligrams per 5 mLs. Notice how this can get a little bit more complicated. Okay, so how are we going to dose Bactrim for this patient? So take 12 and multiply by 4. So we're going to do 4 milligrams of trimethoprim per kilogram per dose. Now what do we do with this 48 milligrams? Divide by 2. Good. Then we have 24. Okay, and then what do we need to do now? So where'd you get 8 from? Yep, so the suspension comes as the trimethoprim component is 40 milligrams per 5 mLs. So you divide 40 by 5 and get 8. So we'll take that 24, divide by 8, and we get how much? 3 mLs. Yeah, so the kid will be getting 3 mLs twice a day. Okay, so it really helps, especially for to make sure that everyone's on the same page when you write that prescription out. Actually, put that in there, right? A lot of computer order entries will kind of do that automatically for you. But if you were to handwrite a prescription, I know it sounds pretty archaic, but include all of that in there. So that way, when the pharmacist is filling it, they can actually double check to make sure that what you wrote is what you intended, and make sure that everything is done appropriately, right? Actually, I had one physician who is a Peds EM trained. Our computer system went down, and so she's like, well, how am I supposed to get scripts? I go, you have to write them. And she said, I've never written one before. And so I said, oh gosh, here we go. So to walk through and tell her how to write a script. But so you guys may have to actually have to hand write that and hand calculate all of this stuff out. Okay, good. Let's say we have a 20 kilogram child who has been receiving 2 teaspoons of acetaminophen 4 times a day for fever, and we'll say that the usual dose is 15 mg per kilo per dose. The concentration you see here is 160 per 5. Is this child being dosed appropriately? So the mom comes out saying, I'm giving him 2 teaspoons 4 times a day. Is this right? How do we figure this out? Okay, so what we can do is what should be first figure out kind of what his usual dose should be. Okay, so let's say we'll just do that 15 times 20, right? So the milligrams per kilogram per dose, we'll do 15 times 20, and we get 300. And so how many ml should that be? So you do 160 divided by 5, and what do you get? 32. Yeah, I hate acetaminophen because it comes as like a 32 milligram per ml concentration, which is really kind of not useful. Like ibuprofen comes as 20 per ml, which is more convenient for doing those calculations in your head. But anyway, so we know that his usual dose should be 300 milligrams. So we're going to divide that by 32. Perfect. So he gets how many ml should he get? 9.375. So we'll say 9.4. And so how much is the kid getting? He's getting 10 mLs, right? Because it's 2 teaspoons, so 2 times 5, you get 10. So, pretty close. Yeah, so I say, okay, maybe give him a little bit less. Here's a dosing syringe. You can drop 9.4 mLs. But yeah, you're not overdosing your kid. Okay? Everyone's still with me? Everyone's like, this is so easy. Wait till the test. It'll be pretty straightforward calculations. You won't need a calculator, but you can do all these calculations in your head, okay? So use your scratch paper. Another thing, fluid dosing for your children, okay, your pediatric patient. How should you figure out fluid calculations? This is really good stuff to know for especially rotations. When you get out there, you'll look like a rock star if you can kind of bounce stuff right off the top of your head. Okay, usual fluid boluses for patients, peds patients, is going to be 20 mLs per kilogram. Okay, so that's a fluid bolus, and then you have your maintenance IV fluid rates you're going to do after that. And so, do you guys know the 4-2-1 rule? Did I already teach it to you guys? Good. Oh, so we'll review it here. So anyway, so the 4-2-1 rule is going to do 4 mLs per kilo for the first 10 kilograms, right? You do 2 mLs per kilo per hour for the second 10 kilograms, and then 1 ml per kilo per hour for every subsequent kilogram past that, right? So you should be able to kind of figure that out based on, if I gave you a patient, kind of figure out your fluid bolus and your rates that you'd need to administer to that patient. So for instance, if I have an 8 kilogram infant, how big of a fluid bolus do I want to give? You get 22 mLs, the fluid bolus. So the fluid bolus, let's do that part first. So 8 times 20, which is how much? 160, right? So again, the smallest bag of fluid you have is 250 bag. It's really easy to accidentally overdo that, right? So that's why I use the pumps to make sure we're giving the right amount to the patient. So good. So we gave him 160 mLs as a fluid bolus, say over half an hour or so. And then how much is his maintenance rate? Right, because we did 4 times 8, which is 32. Perfect. So that'll be his maintenance rate. So you give him 160 ml fluid bolus and then put him on a rate of 32 mLs per hour, and then that would be pretty good for him. Okay. How about a 1,200 gram neonate? You give 24. Right. So you did what?
Made it kilograms.
Good. So you convert it to kilograms. So it'd be, yeah. So it'd be 1.2 kilograms times by 20. Yeah, by 20, and so you get that 24 ml. So notice how small of fluid volumes you're going to be giving some of these patients, right? So these little peanuts, you can't really, don't want to overdo it, okay? And then what would their maintenance fluid rate be? Yeah, like 4.8, so like 5 mLs an hour would be fine for them, okay? How about a 45 kilogram adolescent? Yeah, so 20 times 45 is 900, right? So good. So usually, and kind of a good rule of thumb, if they're above 50 kilograms, like just use a liter, because the 50 times 20 ends up being 1,000 anyway. So it's a good rule of thumb there. And then what would be their maintenance rate? So for the first 10 kilograms, they're going to get 40 mLs per hour. For the next 10,
You're gonna get 20.
you're going to get 20. So is that 60 now? And there's 1 ml per kilo per hour every kilogram after that.
So 85?
Yeah, so 85. So again, it'd be 40, 60, 70, 85. Okay, so practice that. Do a couple times and make sure you can do it in your head. And if you have a 100 kilogram teenager, big linebacker. So we get a lot of these patients because they have the contract with Disney. So at the Wide World of Sports, when they have like cheerleading competitions and football competitions, they actually all come to us when they eventually get injured. So we see a lot of these kind of patients, especially during the summertime. But fluid bolus for him would be what? Yeah, so it could be 2 liters. Like I'd probably start with a liter and see how they do after that, see how they feel, and then you maybe potentially do a second bolus. But again, make sure you're not kind of overdoing it on kind of what the normal adult kind of dosing is. Obviously, if you came in septic or something, yeah, push 2 liters. That's no problem. But take the individual patient kind of into account. And then what would his maintenance fluid rate be?
120.
120. Yeah, so 120 would end up being the maintenance fluid rate for that one, right? So you do 40, 20, and then you have another 80 to put on that. Make sense? Okay, good. I'm not going to give you like a little kind of like gray area like that last one for the fluid bolus, but it'll be pretty clear cut what the question will be, or what the answer would be from that situation, okay? Okay, this is another question that comes up pretty frequently from some of my nurses and whatnot. So say you have a 24 kilogram patient who's receiving lidocaine 1% solution intradermally for a laceration to the face. Okay, the max dose a patient can receive is 5 milligrams per kilogram at one time. How many mLs can this patient receive? So first off, you have to figure out like what the heck does 1% mean? Do you guys know what that means? Basically, it's kind of an old archaic way to express concentrations of fluids, but basically it means that for every 100 mLs of this solution that you have, you'd have 1 gram of lidocaine. Not super useful for the practicing clinician, right? You don't really care how many grams are in 100 mLs, that doesn't matter to you. The rule that you can use to figure out how many milligrams per ml the solution is very easy. Basically what you do with that 1% is you just move the decimal place over 1 spot, okay? So that means for this solution of 1%, how many milligrams per ml lidocaine is there? There's 10, yeah. So again, if I had a 2% solution, it'd be 20 milligrams per ml of lidocaine. Okay, so it's really easy. That works for anything. So imagine if you had like D50, which is dextrose 50%. How many milligrams of dextrose are there per ml? 500, right? So you just move the decimal place over 1 spot, and that can be really useful when you're trying to figure out specific doses and how much volume of how much mLs I want to give to my patient, right? So that rule will work for anything. So you can always kind of fall back on that. So in this case, we said there's 10 milligrams per ml of lidocaine. I said the max that this kid can get is 5 milligrams per kilogram. So what's his kind of max dose that he can receive? How would I figure that out? So do 5 times 24, right, equals how much? it's 120 milligrams the kid can receive. Okay, so that means how many mLs can he receive now? So divide that by? Divided by 10, right? Because you know this, the solution is 10 milligrams per ml, so divide that by 10, and what do I get? 12 mLs a kid can receive total. That makes sense. And so kind of another step removed, but it's a question that comes up more frequently you might know, because like, you know, the nurse, paramedics, like, well, how much can I actually give this patient? That's the way you'd figure it out. Basically figure out what their max dose would be based on the concentration that you have. But for instance, if I had a 2% solution, I can give way less. I only give like 6 mLs for that patient, right? Because otherwise you can run into toxicity issues and whatnot. Okay. So practice this. You can make up your own kind of sample problems. Just make sure you can kind of do it, fairly. The math will be super easy on the test, like be basic stuff you can do in your head. So I'm not going to like give you any. You have a 13, 24 gram neonate, and you have to give some crazy dose of something. Yeah, it won't be. It would be pretty basic for the most part. Okay, so I'm going to go ahead and call it there. You guys have any questions before I let you go? All right, I will see you guys next time.